So welcome to another episode of the Late Aesthetics Show. Today I'm joined by the fabulous Dr. James, who balances the non-invasive procedures with the surgical procedures extremely well. So Dr. James, welcome to the Late Aesthetics Show.
Thank you very much for having me. I'm excited to be here.
We're really going to delve deep into everything great and not so great about the industry today. So let's start with, if you tell the listeners about your journey, how did you end up balancing facial surgery on the NHS, but also running a private practice alongside that?
Sure. So I work in the NHS as a maxillofacial surgery registrar, which means I'm pretty much entering the final year of my training before I become a consultant surgeon. So I'm still at the very tail end of my training. And I work full-time in the NHS, dealing with facial trauma, patients with head and neck cancer, aesthetic concerns as well. We get, patients who have had complications from aesthetic procedures. So it's very much an anatomical specialty, which really makes a lot of sense about why I was interested in non-surgical, because it's essentially, in my opinion, like the same part of the spectrum. So, you've got surgical procedures on one side and you've got non-surgical procedures on the other side. So for me, it made a lot of sense. And I was always fascinated with the head and neck, even when I went to medical school. Yeah. And therefore, it seemed like a normal step into the industry. And then when I got into the industry, I realised that I really, really loved it.
Yeah, fantastic. So a lot of the listeners will know that the industry currently in the UK is unregulated, which is a big, big topic of conversation, which we'll get into in a few moments. Was there a defining moment when you realised that the industry really needs some medical leadership behind it?
I think there are probably two moments. The first one was when I actually decided that I wanted to, do my first course in medical aesthetics. And when I looked at what was available, I was a little bit disappointed. And I thought, and obviously I was at the very start of my journey, but that was the first moment I thought, wow.
How long ago was that now?
That was 8 or 9 years ago now. Yeah. So I was a lot more junior in my NHS career as well. And then the second point was when I started to, do a lot more events myself in aesthetics, educate others, both in the UK and abroad. And I saw kind of that there was a little bit of a gulf between the reality and what was kind of portrayed a lot in aesthetics, both in terms of how you market treatments, also how you kind of mention your own credentials. And that was kind of like the second point where I thought we need to kind of act a little bit more in terms of patient safety, research, but also education is absolutely key.
Absolutely. And that's what you're a big, big advocate for, is the education and the safety aspect as well. So you still work within the NHS. So what is a standard week like for you? If you're not filming, obviously, an episode of the Late Aesthetics Show with me.
Yeah. So at the moment, I've got some study time because I'm actually preparing for my final board certification exam, which is like my consultant exam to become a surgeon. But a usual week for me would be, you're looking at 60, 70-hour weeks in the NHS. So that's a mix of theatre, clinics, on-call, where you essentially do like a 24-hour on-call. So, and then studying for exams around that as well. And then around that, I'm lucky enough to have built in the last few years an amazing team who work on my businesses, which are in aesthetics. So I'm the founding director of a training academy called Interface Aesthetics. And we are a JCCP approved training academy. So we kind of do the level 7, which is the postgraduate diploma. So we have an amazing team, have about 40 people working in that company. So more and more, I'm more of just a founding director role, which I love, not so much of a manager role. I have some great people managing, but still I have to do a lot of the admin to do with that. And usually fitting that in around the NHS is something that has become a lot easier with time. It was quite hard at the start. And then I have my own private patients as well. So I have my own clinic just down the road from here. And again, squeezing that in around, but always with the help of an amazing team. So if I'm organised, then things work really well.
Absolutely. And within your training academy, do you only train medics or do you also train non-medics?
Yeah, we only train registered healthcare professionals, which, would be doctors, dentists, nurses, midwives, who are registered, or international equivalents. Yeah, we only train those. And, being part of the JCCP approval process, which is a process which is essentially giving that level of accreditation. We're one of 4 or 5 academies in the UK that have that. We have to stick to those standards. And that also gives both patients, but also the people who train with us, a degree of reassurance, because it's like a quality assurance process. So we only train registered healthcare professionals.
And since you started in the industry 8-9 years ago, you've probably seen how the industry's really changed over the years. And quite often when I go to conferences, you'll see there's different injectable techniques and it's constantly developing. How do you, let's say, people that come to you training, how do you all keep up to date with what's the latest out there? Science is constantly, advancing and developing.
Definitely. And the way that we do that in aesthetics is very different to how we do it in other areas of clinical practice, like surgery.
Okay.
And that's like something which I'm fascinated by because I have a foot in each camp, which few people do have nowadays. And it says, I know some great colleagues who still do, but I always kind of compare the two. So in aesthetics, you're right. We'll go to a conference and we'll see someone, headlining or with a new protocol that they've just developed, like on the way to the conference.
On the way to the conference.
And then you'll sit there and you'll think, where's the evidence base for this?
Yeah.
Or, why have they incorrectly used that anatomical term? And, it's not to criticize, it's just to say that there is a different approach when it comes to medical aesthetics, which is a great thing because part of what makes it great is that it's so fast moving and innovative. So you can't have a clinical trial for every single new technique in the same way that if we were going to introduce a cancer drug for head and neck cancer, you would need decades of clinical trials for that. So it's not the same, but I think we still can do better. And I've definitely seen it evolve. Things are going in the right direction, though.
Yeah.
I don't want to be, down on it.
Definitely.
They're definitely moving towards people being more robust in their approach, let's say, if they're going to introduce a new treatment or a new product, and that's good.
Yeah, that's amazing. There is a big reality when it comes to complications. I think obviously quite a few listeners would have seen, a lot of what's happening in the news recently. There's a lot of complications that have been brought to light. And you're kind of at the forefront of seeing and dealing with a lot of these complications. So what are the main types of complications that you see in theatre that stem from, let's say, an aesthetic treatment that has gone wrong?
So again, being in NHS and MaxFax is what we call maxillofacial surgery, like shorthand, and being in aesthetics, it's quite interesting because I see the ones that, in my role as a cosmetic physician, but also in my role as a senior reg in MaxFax. And I think from the registrar role in MaxFax, like in the NHS, I've seen everything. I mean, we could go through the modalities just in the past year that I've seen. Toxin causing issues with swallowing. I've seen threads that I've had to take a patient to theatre with a life-threatening airway emergency that I've had to pull out and drain their abscess. Filler. I had a patient who developed what's called trismus, where they can't open their mouth because they had an infection in their masseter muscle, which is this chewing muscle, because filler was injected into that area. I've actually just published a paper on that one.
Wow.
And had to again do kind of essentially an airway threatening emergency that we had to do a procedure in theatre, put the patient to sleep. I've seen fat dissolving injections, which were called necrosis to the skin, that we've had to follow up a patient for months afterwards.
What do you do in that situation? How do you fix that? How do you get the patient back to some level of normality to what they were like, let's say, before they had that procedure?
Yeah, I think it starts from this sounds touchy-feely, and I'm a surgeon and we're the least known for being touchy-feely, but you have to just care for the patient, and like they come in a not very good psychological situation. So that is the first thing. And we need to be sympathetic. Again, this is probably something that in the NHS we can learn a little bit more about. There is a little bit of a tendency, someone has a complication, I'll just go back to your practitioner. Now, especially if they've been treated by someone who maybe shouldn't be doing the procedure, or they don't feel confident, then that's not a valid response from us. So I think making sure that psychologically we treat the patient as we would any other patient, which we do most of the time, I certainly do. But I think, if they're coming to A&E at 2 a.m, we need to treat them in the same way as someone with, coming with an infection or a heart attack. And then beyond that, you need to just really work collaboratively. So from me, ironically, doing aesthetics has now given my role in MaxFax, it's kind of helped it because we have so many complications now. And actually, in the last 5-10 years, there aren't really any other MaxFax trainees. There's maybe 3 or 4 that I can think of ahead of me, who are now consultants, some of them, who have a big foot in aesthetics. So there's a massive gap even in surgeons, whether it's plastic surgeons, MaxFax, general surgeons, of understanding the complications. So, for example, I knew when that patient came with the fat dissolving, what it was that she'd had done, how it had been infected, how it had been injected, what the consequences are, and how you can improve it. Whereas actually, rather than just thinking purely about how surgically you can treat it, you kind of understand the whole process from the beginning.
So you touched on thread lifts, complication associated with thread lifts. I think there's a lot of stigma about thread lifts. Some practitioners do them and really rate them. Other practitioners not so much. Do you think that there's a lot of things that could go wrong with a thread lift, and maybe you have to be very patient selective about who you decide to do that procedure on?
It's a really good question. I think we could dedicate the whole podcast just to that. Personally, professionally, I don't do threads.
Yeah.
And that's not just because of complications. is because I think that for the objective that you want to get from a treatment, threads don't really give me that objective. I'm thinking from like a surgical perspective now in terms of the layers of the face and what you're trying to achieve. Are you trying to achieve a lift, which many people talk about, which it doesn't really do?
No, it doesn't.
Or are you trying to achieve biostimulation, which I think you can achieve in different ways
Without
using a thread lift?
Yeah.
Because we have to surgically remove them if there is an issue, like I had to do in theatre with that patient who had an airway emergency. So for me, I think that absolutely, potentially they do have good uses.
Yeah.
I only know them really from the complications, but I'm probably biased in that because I don't do them. I only see the complications.
Yeah, of course, this is the problem.
So that is kind of the nuance.
If let's say someone has a thread lift, there's a complication, is there a solution to fix that?
Well, it depends on how unwell they are. So I had patients who come to clinic with kind of small areas of skin breakdown where they have a thread and kind of chronic grumbling infection.
Wow.
And those ones can be managed usually with observation, antibiotics, sometimes steroids. Whereas patients who, like the one that I mentioned, who came in with a florid infection, like a really bad infection, his inflammatory markers were through the roof. He had this temperature. He had this growing neck swelling, which could have caused an airway issue. So with him, we had to take him to theatre within 24 hours. So it really depends on the patient, how they respond, what their medical history is. But it can be variable. Two very healthy patients can respond in completely different ways.
Yeah, this is very true. And can threads do they naturally dissolve over a period of time? Or are they literally permanent? Are they always there?
So I'm definitely not...
types,
Yeah, exactly. I'm definitely not a thread expert, but from the threads that I know about, like I said, I do them myself, is that the majority dissolve over time.
Okay.
Unfortunately, we see a lot of unregulated products coming in, so who knows now?
And who knows what that practitioner's using?
Exactly.
And I always think it's really important for a patient to ask the practitioner, what product are you using? That's definitely. You can't just take their word for it. This new one that they've got, well, what is it? Like, it's going in your face at the end of the day, so you kind of need to know what that is.
Yeah.
Do you think the public misunderstand the risks associated with aesthetic treatments?
I think that, I think aesthetic treatments are, this comes back down to like the philosophy of everything we're talking about today. Are they cosmetic treatments or are they medical treatments?
Yeah.
If they are medical treatments, which I believe, and which, not all of them, but many of them are medical treatments, then they have complications. And, even the best practitioner in the world can have complications. Yeah. So it doesn't mean that it's necessarily been done badly. I've managed complications in hospital done by very competent colleagues, in the industry who I know. Yeah. And so that doesn't mean that they've done something badly. So I think that's a key thing. But I think it's really important to convey, using this platform to say that medical training and, holistic assessment and understanding how to manage the complications, that dramatically reduces the harm from any complications. Because the key thing about complications is recognition and management. Actually learning how to inject isn't the hardest thing if you've got someone standing next to you. Yeah. I could point and say, do this, do that there.
Yeah, exactly.
But it's actually being independent and dealing with the complications. And that is the thing that I really, convey to my patients. That, I know what to look out for. You just need to tell me. But what if that patient's not being told that at the end of their consultation? Not being told, if you get numbness or if you get some crusting of your lip, you need to contact me immediately. Because we see that in hospital. They walk in 5 days later. Wow. And they say, no one told me that I had to.
They just thought it was normal, bruising, swelling, it'll go down. Yeah. And quite often, if the practitioner is inexperienced with handling the complications, they'll just say, oh, don't worry about it, it'll go away, it's fine. Is it true? I always thought that if you go to A&E, let's say if you have like a vascular occlusion, is A&E equipped enough to be able to handle that? Or do they not stock highlights, right?
Yeah.
I always thought that A&E don't typically stock highlights.
You are completely correct. And this is the thing that we are raising the agenda about. Thankfully, actually, vascular occlusion rarely comes to A&E.
Okay.
There are a number of reasons, I think, for that. But thankfully, it doesn't. But it does happen.
Okay.
And it's not stocked in many A&Es. So I've worked in multiple A&Es, trauma centres in London, and most of them don't have it. Some of them do. I know where I can find it.
Okay.
Not just my own clinic. If I was on call, I'd run to my clinic. But beyond that, that would be a headache from a medical management point of view.
Yeah, of course.
But it might save the patient. But you can find it in certain places. So, for example, ophthalmologists use Hylays. Anaesthetists use Hylays often when they're doing certain kind of procedures. So in the event of an emergency, it can be found. But if it was overnight, that might be in like a locked cupboard in theatre somewhere.
Which could be difficult to access.
Yeah, and it might delay the treatment.
How quickly, if someone has a vascular occlusion, how quickly do you have to treat that patient?
Oh yeah, this is a key thing. What if it affects your vision, which is the most feared complication?
Yeah.
Unfortunately, research shows you have about 90 minutes.
Really?
90 minutes, and you need to see an ophthalmologist or max fax or someone who can do something with regard to treating that complication a bit more invasively. If it's any other kind of vascular event, it varies, but there are different stages of event, and you're looking at the earlier you pick it up, the better. So if you've got a hint of a problem, I would advise all patients to always contact their healthcare professional. They'll ask you to do a video where you kind of push your lip or where you've been injected to look at what's called capillary refill time, which is how long the blood takes to flow in. Okay. It should be 2 seconds, but in a vascular occlusion, it can be increased. And really, you've got, I would say, if I had any hint, you've got hours to deal with. In reality, even up to a longer period of time, depending on what has happened, you can still treat medically without surgically intervening, and patients can make good recoveries. Okay. But the earlier you treat it, the better. We're talking hours if a vascular occlusion occurs. Wow. At the very most, we're talking 24, 48 hours to really initiate treatment rapidly.
Yeah. Is there any case that springs to mind about a specific patient that you just remember when you think of maybe the most intense complication you ever dealt with? Is there anything that really springs to mind?
Oh, unfortunately, there are too many. There are quite a few.
Well, that's worrying. But I mean, worrying and not worrying in the sense that you can manage that and you can deal with that, so you can restore some normality back to the patient.
There's one really that stands out for me, and this was in my role in the NHS. So I was on call. I was the max fax registrar on call on a normal weekday, and overnight a patient had come in who had come in with essentially, I don't want to be too graphic really, but like pus pouring out of her mouth.
Wow.
Pouring from the cheeks. And when that happens, we think maybe they've got a salivary gland infection, because you've got a salivary gland here. Okay. It produces pus if you've got an infection, or maybe a dental infection that we're not really seeing, maybe like a cancer, we weren't really sure. So on further questioning, and I could see that the patient had had surgical procedures elsewhere. I don't want to go into too much detail to obviously keep it completely anonymized. But I kind of put 2 and 2 together with my consultant, and this patient had had surgical procedures done in kind of a non-surgical environment by someone who wasn't registered as a surgeon.
Wow.
So it had been cut. And if you're cutting someone without being a surgeon, you are mutilating that person because you do not have the training to do it. Something I feel very passionate about.
That should be illegal, right?
It should be.
Yeah, but it's not.
There's a lot of nuance.
Area,
there's a lot of nuance.
Yeah.
I've literally, in the last few months, published a paper about this that's been published in a journal called The Surgeon, where we actually looked at the aesthetics industry. So actually looking at other doctors and how even within our own industry, we need to sort out our own backyard as well. Yeah. But this wasn't even that. This was someone who wasn't a registered healthcare professional in the UK. So I'm not even talking about a doctor who wasn't a surgeon. I'm talking about somebody who wasn't registered, and they were doing procedures on patients kind of in a salon backroom environment. Cutting out bits of skin. In this case, it was buccal fat. So I had removed buccal fat that had got floridly infected. The patient was very unwell. Again, fever, systemically unwell, needed IV antibiotics, admission to hospital. And you know what? Beyond the resources that we spent on that in terms of the NHS and the public, there is a patient at the centre of that. Yeah. Exactly. And we have to manage that patient. And you're not just going to be, well, why did you go and have treatment with somebody who wasn't a surgeon?
You can't
exactly,
do that.
You can't do that. Yeah. But we need to use platforms like this to make it clear that should never happen.
No, it shouldn't. And the thing is, these people, they may even advertise themselves as a surgeon, or they may lead that patient to have believed that they actually are more than qualified to carry out the treatment. Obviously, if you're going and getting surgery in anywhere that isn't a sterile environment, that definitely should raise some red flags. And you should definitely be a little bit more cautious about those situations. But this is why this type of platform's great, because it will make the patient think twice. Absolutely. And that's the best that we can achieve. Think twice about it before you make a decision, and never be pressurized into having a procedure. Take your time to think about it.
Yeah, absolutely. And I think that, for patients watching, like you say, where it's being done, but also who is doing it. Those two things. And you can really easily check if someone is qualified now. There are a few easy ways to do it. So just make sure you're looking after yourself, because it's your own health and well-being at the end of the day.
What are your best tips for if a patient would like to check if a practitioner is qualified?
So if they're going to be having a cosmetic treatment or aesthetic treatment, if they come across a social media page or a profile, then number one, checking that person is a registered healthcare professional. So there are public registers for the GMC, GDC and NMC, for example. And then, so that's the first thing. If they don't meet that standard, then, they're not going to be a registered healthcare professional. And then beyond that, if they're going to have a surgical procedure, it is really quite clear. You literally just check on the GMC register again, and you can see if that person is a specialist on the specialist register. And if they're not, then they may still be qualified to do surgery, but it just needs a bit more clarification. Whereas if someone is on the specialist register, they are a surgeon and they can do that procedure.
Okay, brilliant. Where do you think we stand in the UK when it comes to regulation? You've touched upon it's moving in the right direction. Do you still think that we've got a long way to go?
Definitely, we've got a long way to go. But we're in a much better position than we were a few years ago.
Yeah, definitely. So it's just taken a hell of a long time. That's the problem. What are your thoughts on non-medics, who are injectors, and they then train other people how to do treatments?
I think that it's problematic for doing certain procedures. So doing surgical procedures, obviously, which I've seen. Yeah. Completely non-medical people teaching others to do surgical procedures, and also injectable procedures where you can get quite severe complications. And I say that coming from, people watching on non-medical injectors might watch this and think, who's he to say that? But I say that from a non-elitist position. I went to state comprehensive school as the first person in my generation, first generation to go to university, only person in my state school to go to med school. And I have thousands of pounds of student debt of 18 years of training to be a surgeon. So I'm not coming from an elitist position here. I wasn't handed with a silver spoon, but I've also seen how long it takes to do these things well. So I think that I'm not trying to put anyone down, but I definitely think that we need to have a degree of insight into the things we don't know. We don't know what we don't know. And, I've seen people teaching anatomy using, incorrect facts, incorrect information, calling things wrong things, and essentially giving false information. And, in the age of social media where everyone can disseminate information, there needs to be some kind of safeguard. And, going back to talking about practice, the way we improve practice and regulation is through education.
Definitely.
That's the key.
But even things like people rely a lot on ChatGPT these days. But even like ChatGPT, it doesn't have a medical background, right? And it spouts out things that are just completely inaccurate.
Absolutely.
Even for someone like myself who is a non-medic, it's like that's not accurate whatsoever. So that's quite dangerous, because if someone gets access to that type of information, they'll think that what ChatGPT is saying is correct, and then they'll use that as like their form of education. Definitely. Which is that's very, very worrying for sure.
Definitely. And I think now that I'm studying for my board certification exams, which is called FRCS in the UK, I'll study a topic in the detail to, hopefully become a consultant facial surgeon. So pretty good detail.
Absolutely.
And then I will check it on ChatGPT, and there are inaccuracies there. And you could read it if you had a little bit less information and think, oh, wow, this is amazing. But actually, when you, go through it with a fine tooth comb, there are inaccuracies. So, it's a great tool, but it needs to be used with care.
Definitely. What does the regulated industry in the UK look like to you? If you could be solely responsible for sorting out the mess that is the lack of regulation in the industry, what would you do, and how would you go about doing that?
So I think I would, again, go back to that point. It starts with education. Education. So if you can get regulated education and an agreed educational standard, let's draw a comparison. If we had issues with the quality of doctors in the UK, but we didn't monitor medical schools, where would we start?
Exactly.
We'd go back to medical school. Because actually, if anyone off the street said, I'm going to be a medical school professor now, which is what we have in aesthetics, someone can come off the street and say, I'm setting up my own training academy. So the same is true of aesthetics. We need to go back to education and monitor the quality of training and have an agreed standard. If you are going to be practicing, you need to meet this agreed standard, which has been agreed with key stakeholders, the government, the JCCP, all of these bodies that are important.
Absolutely. And that's really, really, really important. Do you think that just having a training academy is important, or do you think that a lot of training academies have become far too commercial? And again, they're missing out on the fundamental thing that is the education. Because if you think about schooling, the schooling system, for example, Ofsted go in there and Ofsted make sure that the schools are at a specific standard. And if they're not at that standard, what will happen? They'll have to improve that standard. That, I think, needs to be very apparent with the education side of things. So do you think that just having a training academy is enough, or do you think some of them are far too commercial?
Yeah, it's a great point. And obviously I might be a little bit biased on this because I have a training academy, but there are essentially two tiers of training academy in the United Kingdom at the moment. There are academies that are externally quality assured and JCCP approved, of which we're one of those.
Yeah.
And our academy is subject to everything that you just said.
Okay.
We voluntarily open up ourselves to be, reviewed and assured.
So it's like if a clinic is CQC registered,
Correct.
for example.
Correct.
That's an optional
Yeah.
thing that they can do. Yeah.
Absolutely.
Yeah.
But only the minority of training academies have that. And the vast majority don't have that. And I think in answer to your question, absolutely it's become commercialized. It is a business. Education is a business. I'll give you an example. I saw a video the other day from a training academy somewhere. And it was essentially showing, it was bizarre. It was completely bizarre. It was like promoting injecting a prescription-only medicine without any indication. So it was a prescription medicine without giving the indication. But not just that, the lighting was like you were in a nightclub. The music behind was like some kind of 80s adult film. It was bizarre, bizarre.
Yeah.
And I thought this is where we are at in terms of, training providers at the moment. And this is really a shame. But like I say, you've got kind of two tiers and you need to make sure that, we just stay in our lane and hopefully the regulation catches up with us.
And is it okay if a patient asks that practitioner where they were trained? Do you think that that's okay?
Yeah.
Yeah.
Absolutely. I think they should. They should definitely be fully informed and the practitioner should be completely transparent. And they shouldn't just say Harley Street trained. That doesn't mean anything. You need
No,
to.
it doesn't mean a thing.
Yeah, you need to understand that, anyone can set up a clinic on Harley Street.
Yeah.
So, definitely as a patient, be empowered and be informed.
Yeah. So obviously with your surgical background, how do you think that has influenced how you approach injectables?
I think to be honest, they have helped each other massively. And this is the thing people don't talk about that much. My work as a cosmetic physician, like I mentioned earlier in the talk, has helped my maxillofacial work because it gives me that insight. And you know what, in the next 10 years, when we have 3 or 4 times the number of complications, I know that my work in aesthetics is going to really help me as a maxillofacial surgeon. But vice versa, I say it goes back to the fundamentals of anatomy because the thing that gives you good outcomes for your patients, and this is another thing to patients, if you're not getting a thorough assessment, run a mile. And as a surgeon, understanding the anatomy, we are trained to really think about the anatomy and think about the layers of the face and also think about the broader context of that patient. Your skeletal anatomy. In MaxFax, we're dual qualified, so medics and dentists. So think about the dental anatomy. Think about how all of that interplays. And for me, as part of my training in MaxFax, we have to, as I say, do medicine and dentistry. So when I went back to dental school, it taught me so many different things about the facial profile, about facial harmony, about the differences between men, women, ethnicity, how our dentition and bones change as we age. So I think it definitely upskilled me in aesthetics without even knowing that it would.
And that's not the type of thing you can just learn, during a weekend or 1-day course, 2-day course, an online course. That's just not the type of knowledge that you'll pick up from that whatsoever.
Definitely. It's definitely something I try and incorporate into the training that I do now because it was so useful for me.
Fantastic. Have you seen something like filler being completely injected into the wrong area of the face? Because people think, filler, it's easy, that it's not difficult to do. But have you seen it being injected in bizarre areas in the face?
Yes, too many times.
Really?
Both in videos online, probably mostly in videos online. And then the explanations about why it's being injected there, not really making that much sense. And then even in major events, I've seen it, like on stage and it's just kind of a bit of an eye roll. It happens less and less because the companies that often finance the big events, they are becoming a lot more aware of the need to evidence-base everything they say, not just say, this is amazing, actually have a trial or, evidence that this procedure works.
Yeah, definitely.
But it still does happen.
Well, even there's trends on TikTok, like the Russian lip trend, for example. A lot of practitioners are against that trend, but it was a big trending topic on TikTok, which then obviously the younger generation will see that. They'll call up the clinic and say, hi, can I get some Russian lips, please? What are your views on that technique?
Yeah, I mean, if someone says that, I just take it as a moment to have like an educational moment.
Yeah.
Because Russian lips is aesthetics is not like when you go to a sushi restaurant and you tick the boxes of the food you want. Aesthetics isn't like that.
No.
And actually, that is what that essentially is. It's like I want the chicken ramen. Like I just want the Russian lips. With actually, you need to trust in their professional skills and actually sit down. I'm going to take time to assess you.
Yeah.
And what they mean by Russian lips may mean that they need some volume here and some vertical height there. But I never call it Russian lips, and I try and have an educational moment when something like that comes up.
Well, you're quite right. Everyone's anatomy is so different. I can remember like years ago on Love Island, for example, there was a big like press article that came out, and everyone was saying that all these people, they look identical. Have they been to the exact same like injector? Because some injectors, they've got one way of injecting and they'll just inject like that. But really, you need to understand that individual's anatomy, their facial structure, bone structure, how they're going to age in order to create a treatment plan that's going to last a long period of time and give them the results that work for them as well.
Certainly. I mean, maybe all the injectors went to the same training academy. I'm not sure. Maybe that's what's going on. Yeah.
But even there's injectors, for example, that have been trained with one specific type of filler and they only use, or they're only comfortable using that one type of filler.
Yeah.
But for me, I think it's a case of understanding the different types of filler you can have, the individual, and using your techniques that obviously you've developed over the years and, adjusting to that specific situation.
Yeah, absolutely.
Okay. Do you think that you approach the consultation process differently because of your work during the NHS? Do you think you spend more time, you have more like empathy? Do you really take your time like during the consultation? Because I've always thought consultation is the fundamental thing. That's your starting point. Without a thorough consultation, you can't make a thorough treatment plan. So how do you approach the consultation?
I think that probably training in the NHS gives you different skills and insights. But also I think working full-time in aesthetics gives you different skills and insights. And you know what? There are things that in aesthetics, sometimes we can learn from the NHS and vice versa. So I probably don't think my training in the NHS has changed the way that I approach the consultation beyond kind of really looking at the face in a completely multidimensional way and really focusing on the assessment and keeping anatomy focused. So I think that's probably been the main thing. But how I actually conduct the consultation, I think that done well, in medical aesthetics, whether it's NHS or aesthetics, we are healthcare professionals and we are trained in how to manage patients. So
it's having that duty of care, isn't it? That's fundamentally what it comes down to. So I think the viewers now understand you're definitely a change maker when it comes to the industry and very, very thorough educator. When your, let's say, students come to you, are there any red flags that you give them about approaching the aesthetics industry?
Yeah. So it's the same thing that I would say to patients, actually. Do your research.
Yeah.
Because aesthetic medicine training is not formalized. There's no pathway. In the same way in maxillofacial surgery, I know that if I complete my exam and in 1 year I'll be a specialist. That doesn't exist in aesthetic medicine. So you need to really choose your mentors carefully, your trainers carefully, and you need to build up a network, like a tribe. Some of my colleagues talk about have your own tribe of people. And that's the main thing I would say. Really make sure that you make those informed decisions. And then that goes the same for patients, in aesthetics, because it's just a little bit less safety netted than other areas of clinical practice.
Yeah, and also I think with colleagues, you can share ideas with each other as well.
And the hard times.
Yeah, exactly.
Complications.
Yeah.
Because it can be really lonely.
Yeah, exactly. Yeah, it can be lonely. So it's good to have a support network of people that you trust and will give you, their professional advice as well.
Absolutely.
Okay, so let's have a little quick fire round. So, is there any filler that you would never touch?
Absolutely. Yeah, anything permanent.
Okay.
Anything permanent.
Yeah.
One of the things I didn't mention actually when you asked about complications, I work in a place where we have a consultant who's developed a practice of patients who were treated with permanent fillers 10, 20 years ago, either for cosmetic or because they were taking medications like for HIV.
Okay.
And they are all coming in with horrendous granulomas and complications.
Wow.
And they're things that really happen years down the line. So not only does it not look good, but actually any permanent filler, things like silicone, PMMA, the one we treat is called bioalchemid, which was used a lot like 10, 20 years ago.
Wow.
So nothing permanent ever.
How do you is that literally you have to surgically remove that filler?
Absolutely.
Wow. And there's obviously risks, complications,
completely. Scarring.
time.
Yeah, completely.
Yeah. And if it's your face, then yeah, definitely. Is there any celebrity that you look at and you think, yes, their injectables have been done very, very well?
Oh, So I will caveat this because we don't actually know what they've had done.
Yeah, no. People always guess, or they assume that this, and this.
And I'm not that practitioner. In fact, I'm quite against that practitioner who will go on Instagram and, you know, say this person had this. Because actually, we don't know what they've had done.
Totally.
And they are still a patient.
Yep.
But I think, you know, I'll give you a comparison, actually. I think it comes down to the person. Everyone at the moment is comparing J-Lo, who looks amazing.
Yes.
Of course she looks amazing. She's stunning.
Yeah.
And Cameron Diaz, as if Cameron Diaz is like down in the dumps. But you know what? Cameron Diaz has maybe chosen some different journeys. But you know what? If that's right for her and she's happy, she still looks amazing. Pamela Anderson's another one who people talk about.
She looks fantastic, doesn't she?
Exactly. And people talk about, you know, she doesn't look like a beauty norm of what we're used to in the last 10 years, which is, like you say, a little bit cloned.
Yeah.
But actually, she's happy, then that's the key thing. So I think
she looks great.
I've drawn all three of those. You know, they all look great. They're doing what's right for them. They all look great.
Yeah, I agree. Is there any myth in the industry that you think is like, please stop saying that?
There's one key one. It's about toxin injections, so anti-wrinkle injections. So this is a prescription medicine. Yeah. So anytime you have that, you need to see a healthcare professional. But something we get quite commonly is that patients and healthcare professionals say that, I need to change the type of toxin I'm having because I've become immune to toxin.
I've heard that a lot as well.
I have to rotate around a different one. It's because of the proteins. Well, I've done quite a lot of research with one particular type of toxin, and therefore I have done a little bit on the others. And the evidence shows we've got studies of kind of 30,000 procedures, many thousands of patients, and it shows the actual antibodies produced are so low. We're talking less than 0.5% of people. And even when we're doing like really high doses, because some patients who are unwell, like who have a stroke or something, we need more high doses. And that study even included high doses. And even then, the amount of antibodies are low. The key takeaway for patients here is that actually the thing that does increase the chance of you getting immune is if you have it too frequently. So going for a top-up unnecessarily or having it less than 3 months apart, those things do increase the chance of antibodies. But actually, if you've got a responsible practitioner leaving at least 3 to 4 months, your risk of actually being immune is low. And it's probably something else like injection technique or dosing or any one of those things.
That's really interesting because I have heard that a lot. I need to go to a different injector, even in my clinic, for example. So people will inquire and say, I've been going to this practitioner for years. My Botox has stopped working. Can you help?
Yeah.
Hang on. And that's a bit of a red flag. Like it's very, very much a red flag.
Again, educational moment, right?
Definitely.
We can have that with our patients.
And it's important because when you're a trusted clinic, the education is a vital part of that. You need to, even if that patient doesn't come and have treatments with you, at least you've given them the education so they're going to make more of an informed decision.
Absolutely.
What's in your own skincare routine?
Oh, quite basic actually.
Yeah.
So I have no connection to them, but I use SkinCeuticals products.
Yeah.
I just kind of sea ferulic, Pitox, and then I use kind of hyaluronic acid. And I use a retinol at night as well, although I'm not so good at using that, just with like all of the hours, and sometimes you're doing a night shift and you don't know if you're waking up or going to sleep, so that can definitely improve. Yeah. But I try...
SPF?
Yeah, absolutely, SPF, every
definitely.
day. Yeah.
Did you not see recently, there was Sam Fairs from The Only Way is Essex, she came under fire this week, purely because she put a statement out saying that children, she doesn't put SPF on her children because they will build up tolerance to the sun. And now, obviously, loads of dermatologists are jumping on the back of that saying, hang on, that's not great advice to be putting out there. You need to wear SPF. But her whole concept is when you're in the sun, you build up a tolerance. And they're like, that's not true whatsoever. Like, the sun obviously does damage you massively. So wearing SPF is highly important and it shouldn't be disregarded.
And listen to board-certified healthcare professionals. And not this, saying that other people's perspectives aren't important. But when it comes to something like skin health, we're talking about, catastrophic things like cancer and sun damage. And not to mention that, this is an aesthetics podcast, aging. It causes accelerated aging.
Yeah.
And, it starts when we're kids.
Yeah,
so,
exactly.
definitely this is dermatologists.
Definitely, absolutely. Is there any aesthetic treatment that you secretly love?
I'm not sure if I would say secretly. I think I'm quite out of the closet with all of the treatments that I like. I think that there is no substitute for the bread and butter treatments that we have. I think we lived through quite a few bubbles recently.
Yes.
So there was, in the decade just gone by, kind of 2010 to 2020, we had a bit of a bubble with filler. Yep. And now we're having with regenerative. Yep. And I think they're both valid. And I think we're going to see a stabilization. I think, filler's down here, it's going to come back up. And we're going to see that actually it's about the assessment. You know, filler can't treat skin concerns or dark circles, but also regenerative treatments can't treat volume loss.
Exactly.
So you need to have a mix of both. And I think we're getting to that point.
And they're very different things as well. I just don't think it can be one or the other.
Absolutely.
And people so far just seem to have replaced filler with the likes of polynucleotides.
Correct. But then people are now seeing that
yeah.
the results aren't. As in, polynucleotides are amazing. I use them in my own practice. But it's about choosing the right indication. And we know that multimodality treatments, so combining treatments, tend to be the way that you get best results.
Absolutely. Well, you've just answered my next question, really. The trend where it's going is definitely more natural results, but it's a combination of things that you can do to address the volume loss, the skin texture, laxity, and obviously stimulate some collagen within the skin, because that's all what's going to lead to healthy aging.
Yeah.
How do you think that the aesthetics industry can become safer and more ethical in the next decade? We've kind of gone through this in the sense that it definitely starts with education.
Yeah, so education I think I've talked about, and then and that starts with us as training providers as well, making sure that we have businesses, but it's not purely commercial because we have a registration with the GMC. So that makes us different, and I stand by that as a hill I will die on. We can't just behave like startups in Silicon Valley where we want to just make as much money as we can. We cannot, because patients are at the end of our needle. So that's the first thing. And then the second thing really quickly is about research. So we need to invest more in clinical research and make sure that we're not just producing research to, you know, promote ourselves or, you know, promote some technique that no one's going to look at again. There needs to be more studies. That has to be in collaboration with the big companies. So, but it needs to be, you know, a moderated and responsible collaboration with the big companies, because that's how big research is done. It's how it's done in every aspect of healthcare, actually. And it just means that we have to have, you know, ethical, like-minded healthcare professionals who, you know, are able to access those resources, but also not just play completely to the fiddle of a major company. So
Absolutely.
I really hope that research will be a bigger part of what we do in the next 10 years.
Thank you so much. That just finishes up really, really nicely. If any of our listeners would like to get in contact with you, how can they get in contact with you?
So probably the best way would be just by my Instagram handle.
Which will be tagged in the bottom. Yes, it will be tagged in the bottom. And your website link will be shared as well. So thank you so much for being such an insightful guest. I really hope that the listeners have picked up some valuable information and that they think about what they're going to do when it comes to procedures. So thank you so much.
Thank you for having me. It's been great.
Brilliant. Thank you.